Following up on the videos that you watched in part 2, nursing care of ET tubes, chart 34-10. Of course, your ET tube is going to depend on whether it's inserted or intubated through the naso or oro. Also, if it is lodged in an incorrect placement or yanked out very forcefully, and etc. If those are the cases, then your care may change a little bit. But on a regular basis, while taking care of your intubated client, assess that placement, assess breath sounds, check for cuff leaks, chest wall movement, any signs or symptoms of hypoxemia. We only want to utilize restraints as the last possible resort if your patient requires them for accidental extubation. Suction as needed. Complications either occurring during the placement, while it is in place, or during extubation, or maybe even after the patient has been extubated can occur. There can be trauma or complications. Pulmonary areas can be damaged, esophagus, esophageal, gastric areas, cardiovascular, musculoskeletal, and neurological systems can be damaged during placement, while it's in place, and while we're being extubated. Now, any time that there is a tube in place, it is going to cause some degree of irritation, which is going to increase the risk for possible damage. And the longer that the placement is needed, then the higher the risk for damage. So moving from endotracheal tube into tracheostomy tubes, we're going to put in a tracheostomy if the patient requires mechanical ventilation for more than 10 to 14 days, because the tracheostomy tube is going to reduce tracheal damage and vocal cord damage as opposed to the ET tube. Parts of your tracheostomy tube, figure 30-13. Tracheostomies can be temporary or permanent. An airway must be established, so regardless, initially your patient may require an ET tube in preparation for the tracheostomy tube, because your tracheostomies are performed in the OR by an anesthesia team or surgeon's guide. So initially the ET tube is placed in, and then after the trachea is entered in the OR, the ET tube is going to be slowly removed while the tracheostomy tube is being slowly inserted simultaneously. The tracheostomy tube is going to be secured, and then a chest x-ray is going to be done to ensure that it is properly placed. Tube obstructions. Sorry, I went too far again. Initial postoperative care by the nurse. Tube obstructions can occur from things such as pus accumulation. We never cut a gauze that is put around the tracheostomy. You learned that very early in your student nursing career, because a string could come off of the gauze and be lodged in the tracheostomy. Other obstructions could be from edema or dried secretions. Assess for any client complications. Look for those breath sounds. Assess, auscultate. Possible complications continuing on, certainly tube dislodgement or decannulation, a pneumothorax. You can see the first image is blood in the pleural space, which you now know is a hemothorax. The second image is the collapsed lung or the pneumothorax. We've already discussed sub-Q emphysema, or that Rice Krispie under the skin when palpating sound. Bleeding and infection. If the tube on an immature tracheostomy is dislodged, it requires that you ventilate the client using a manual bag or a face mask, while another nurse calls for the rapid response team. Air warming and humidification. We have to do that because when we put in these tracheostomy tubes, then that part of the body's natural mechanism is removed. We're going to suction as needed, maintaining that patent airway. What does that crackling sensation around a tracheostomy while palpating indicate? When should you deflate the cuff when preparing to cap the tube with the decannulation cap? What is the ideal temperature range of the air entering into the tracheostomy, as well as what temperature should never be exceeded? These are also polls that we'll discuss in class. Your types of ventilators. Types of ventilators. It's dependent upon the severity of the disease process and the length of time that your patient is going to require ventilator support. Negative pressure in the chest cavity, it's changes rather than forcing air directly in. The negative pressure type of ventilator does not force inspirational air into your patient lung. However, the positive pressure, it does force inspirational air during inspiration. That pressure is gently generated and it pushes the air into the lungs and thereby expands the chest wall. And the different types of your negative pressure ventilator and your positive pressure ventilator are listed there for you on the slide. Page 677, the modes of ventilation. The mode of ventilation is the way in which your client receives their breaths from the ventilator. AC ventilator. If the client does not have spontaneous breaths, the AC ventilator is used. The vent will establish a ventilation pattern. The AC ventilator mode delivers 7 to 10 milliliters per kilogram of air to the client. Synchronized, intermittent, mandatory ventilation is similar to the assist control ventilation in that a tidal volume and a ventilatory rate is preset. But unlike the AC vent, your SIM vent allows for your patient's spontaneous breathing at their own rate and tidal volume in between the delivered ventilator breaths. The SIM vent can also be used when an attempt to wean the patient off is done, and when it is used for weaning the patient, the rate is decreased gradually from a delivery of 12 breaths to a delivery of 2 breaths during the weaning mode. Your BiPAP provides for a non-invasive pressure support ventilation. This is usually done via nasal or a face mask. It is used for your clients who cannot undergo the invasive procedures such as ET or tracheostomy tube. The oxygen delivered to the client is warmed to body temp. It is also humidified to 100% because of that upper airway passage of the respiratory tree being bypassed. We do not want to cause mucosal damage, and that's what would happen if it wasn't warmed and humidified. It is important to lower the FiO2 that is delivered whenever it is possible, because a prolonged use of a high FiO2 can actually damage the lungs from the toxic effects of oxygen. So we don't want our FiO2 to be at a rate higher than 60 for very long. It becomes a critical concern then. Your tidal volume is going to be set to deliver 7 to 10 milliliters per kilogram with each breath, and that is of air. Your rate is the number of ventilator breaths that will be delivered to your client per minute. It's usually 10 to 14. Your FiO2 is a fraction of inspired oxygen. It is the level of oxygen that we will deliver to the client with the ventilator, and it's going to be between 21 and 100%. Your PaO2 should be maintained between 80 and 100. Your peak airway inspiratory pressure is the pressure that is needed by the ventilator to deliver that set tidal volume, and it's going to be the highest pressure that is reached during inspiration on the client. Your O2 saturation should be maintained at greater than 90%. Continuous positive airway pressure, or CPAP, is synchronized intermittent mandatory ventilation mode. It applies positive airway pressure throughout the entire respiratory cycle, and this is for your spontaneously breathing clients, and it is also utilized in the weaning process. The normal levels of CPAP are 5 to 15 centimeters to promote adequate oxygenation. PEEP should be increased in arterial blood oxygenation so that the FiO2 can be decreased. Remember, we don't want to leave that FiO2 very high for very long. The amount of PEEP is usually 5 to 15 centimeters of water. Now, if the client becomes agitated or restless or has a wide fluctuating expiratory pressure reading, or they have other signs that indicate air hunger, it's possible that the flow rate on the ventilator has been set too low. Now, your flow rate is how fast each breath is delivered. It's usually set at 40 liters per minute. So maybe it is that you need to increase the flow rate, and that should be tried before initiating any further usage, possibly restraints or whatever like that. So it may be that your patient is experiencing air hunger because the flow rate is too low, and that just needs to be increased a little bit. When caring for your ventilated client, always check the client before you check the equipment. Your priorities are to monitor and evaluate your client and your client responses, manage that ventilator system safely, and prevent complications. If the client develops respiratory distress during mechanical ventilation, immediately remove the ventilator and provide ventilation with a bag valve mask device. This will allow a quick determination for the nurse of whether the problem is actually the client or if the problem is with the ventilator. Also, to prevent bacterial contamination, do not allow moisture to set up and water to set up in the ventilator tubing that enters into the humidifier. Look at the slide and ask yourself, what do you see repeatedly on the slide? And of course, the answer to that is assess. Do not rely on your equipment. Do not rely on alarms on your equipment to direct your client care, but rather rely on your client's responses, the symptoms that you see, the assessment that you're making, any changes, no matter how subtle. You should assess your vital signs and breath sounds for this client every 30 to 60 minutes, and always PRN. You can always do it more than that on any client in your care who is ventilator dependent. Utilize your ability to critically think here and apply your nursing knowledge. Certainly there are special considerations. The older the client is, a client who has smoked for years and years, or a client who already has chronic lung problems such as COPD, certainly is going to be at a greater risk for ventilator dependence and a failure to be able to wean off of the ventilator. Things such as an increased chest wall stiffness, reduced ventilatory muscle strength, decreased lung elasticity. These are all contributing factors to age-related issues. Also, signs of hypoxemia and hypercarbia, or hypercarbia is an abnormally high level of carbon dioxide in the circulating blood. These may be less obvious in the older adult, so other indicators such as a change in mental status should be used to help determine if there are worsening breathing difficulties. With an ET and a tracheostomy, anytime extubating, always bring to the bedside the equipment that you're going to need for emergency re-intubation. Hyperoxygenate the client, suction as needed. Rapidly deflate the cuff and remove the tube at the peak of inspiration. Instruct your client to immediately cough. We want to know that that cough reflex and gag reflex is there and present. Monitor vital signs every 5 minutes at first and assess the breathing pattern. We're looking for any respiratory distress. Early signs of difficulty might be mild dyspnea, and then a continued uncontrolled coughing. We do want them to cough, but if they continue to have that coughing uncontrollably, that's a problem. If they display an inability to clear secretions or clear their throat. If you assess the patient to have a stridor, stridor is a high-pitched crowing noise that is heard during inspiration. A stridor is due to swelling and maybe also due to laryngospasms. This is considered a late symptom of a narrowed airway. It is an emergency. Racemic epinephrine is a topical aerosol vasoconstrictor. It is given when re-intubation may be needed. So what you would do is put this topical aerosol vasoconstrictor on, hopefully decreasing the edema, making it possible then to re-intubate. You're going to have to act quickly to prevent this airway from becoming completely obstructed. Remember, you cannot put a tube down a closed airway. So this emergency, this stridor emergency, may rapidly progress to the need for an emergency tracheostomy.